Welcome, I'm Whitney McKnight, and we're here today at the University of Maryland School of Medicine, where we are going to discuss the new Zika vaccine under development at the Vaccine Development Center here at the school. And I am here with Dr. and Dean E. Albert Reese. He is the Dean of the School of Medicine, and he's also our masterclass columnist at OBGYN News. So welcome, Dr. Reese. Thank you very much for having us here today.
Thank you.
And we are joined by Dr. Kathy Newsel, who is a professor and the director of the University of Maryland's Vaccine Development Center, and also Dr. Chris Harmon. He is a professor and chair of the OBGYN department. He's also the director of maternal fetal medicine here at the school. So I'd like to begin actually by talking with you, Dr. Reese. Tell us about the university's involvement in this Zika trial. This is a big deal.
Well, the School of Medicine has had a very long history of involvement in vaccine development, first of all. In fact, our history goes back over 40 years with one of our leading professors, Dr. Mike Levine, who actually began this center. And so it has been very much a resource, not only for the School of Medicine, but really globally as well. And so we've actually have done trials for a number of other emerging infections, whether it be Ebola or H1N1, and of course now the Zika. So we've had a very long history of supporting, developing, testing vaccines, and so our reputation is well established across the country and across the world. So it's not unusual for this to occur. I think probably the most impressive was when the Ebola was at its highest height, as it were. And at that time, we got a call, would we be willing to test an Ebola vaccine candidate? So that really was unique and rapid. Likewise, Zika in the same situation, and we're also willing to be helpful. So we're well set up, well established, and well prepared to be involved in that trial.
Now, do you only work with the National Institute of Health, or do you work with private developers of vaccines as well?
We do both, but our funding, we do original research that really starts from the bench to translational, to clinical trials, to field trials. So we do the whole spectrum of vaccine development. Our funding comes from the NIH, which is the federal, but we have a lot of funding from the Gates Foundation that really supports our worldwide footprint. So it's rather broad. We have Wellcome Trust for funding as well. So it allows us to not only do original vaccine development work, but also test vaccine candidates that have been developed elsewhere, like at the NIH.
I see. Okay, so that's a good place for us to turn to Dr. Newsel and have you tell us a little bit about, just in general, how the trial is going and what we can expect time-wise.
Sure. So this is a phase 1 trial. So this is a first-in-human trial, which means our primary outcome that we're looking for is really safety and tolerability of the vaccine. So we are following all of the volunteers very closely, both for side effects that might be fever or local reactions, and then also longer-term safety. So there are 80 total people that have already been enrolled in this trial. And as many people know with phase 1 trials, we have halting rules, which means that, you know, if we saw something even early on that we were concerned about, we would stop the trial and reevaluate it. And that hasn't happened. So that's good news. So the trial is proceeding with these 80 people. They'll be randomized, so they will get either 2 or 3 doses of this DNA vaccine, and they'll get it at different intervals in terms of a month, or some will get it at 2 months. So we're looking at how the timing of the vaccine might affect predominantly the immune response. And then we're looking for both the short-term immune response. So once you get that vaccine series of 2 or 3 doses, what's your antibody, what's your cell-mediated response 1 month later? And then we'll also be looking at longer-term responses a year or 2 later. Those will tell us more about the durability of immunity. Those won't be primarily used to make a decision on if we go forward into a phase 2. That will be the shorter term immune responses that we'll have in months. Then we'll make a decision whether we move into a larger number of people.
Okay, so phase 2, when would we anticipate? I think Dr. Fauci at the National Institute of Allergies and Infectious Disease had said beginning of 2017.
Yeah, phase 2 could obviously, the decision could be made and we could be very actively planning for that in early 2017. And again, that would look then at a larger number of participants.
And just here in the US?
That actually has not been decided. It is possible that a phase 2 could include some of these other countries where Zika is endemic.
Right, okay. When will you know that then, and what kinds of criteria you're going to be looking to meet in order to make that an international trial?
Yeah, and again, it's really the NIH who's the study sponsor, and so they will ultimately decide. I can tell you the criteria that we've used before for this. I mean, obviously, as I've already mentioned, safety and tolerability must be foremost. Mm-hmm. And then we'll be looking and comparing antibody responses, because again, we're testing 3 different regimens. If 2 vaccines gives you as good an immune response as 3, it's certainly easier from a programmatic perspective to go in with 2 vaccines. So these are some of the ways that the decisions will be made on when and how and what regimen to take into phase 2. I think that is the advantage of these current vaccines, these DNA vaccines, because they can be manufactured in large quantity in relatively short periods of time. So that's the good news. Currently, we've tested several DNA vaccines in humans. There aren't any currently licensed, but several have been tested in humans. And the fact that they had been developed and tested previously actually allowed us to move more quickly with both developing this Zika DNA vaccine, which was developed by the NIH, and to allow us to move more quickly into humans.
So, Dr. Herman, what's really interesting about this entire infectious disease crisis is it's the first time that we've ever had pregnant women really be at the center of the response. And obviously, they are the cohort that's the most concerned, although it can affect anybody. I suppose we don't really know the parameters completely, but since you deal a lot with maternal fetal medicine, what do you think is the most important thing for your population of doctors to be taking away from this now? What should they be looking for, and what can they do in the meantime to comfort their patients?
I think it's first important to have perspective on the Zika epidemic. Rubella is every bit as virulent, as damaging, and as threatening when it's untreated, when there's no viable immunity in the host pregnant woman. But we've solved that. So I think the bright light, it's over the horizon currently, but the bright light is the development of an effective and durable vaccine which will protect all women, subject to public use of a widespread vaccination program. So that's the first sort of positive note. The second positive note is that we know that a large number of people have been exposed to Zika, and only a small fraction of those women have affected babies. So this isn't an epidemic with massive implications of severe damage and generational impacts such as Ebola. This is a virus that has a predilection for neural tissue, and because of that the effects are devastating when the fetus is infected, but it doesn't have any residua if the baby is not affected, and that has to do with timing of the infection and probably has to do with dosage as well, but some of these details are being worked out. As a gynecologist, I have to refer to one of our tenets that's been existing forever and ever. Planned pregnancy is essential. And so this puts the burden on the couple or the woman. Really, don't get pregnant if you're in an endemic area, and don't have a partner that's been in that endemic area recently, because Zika can affect your baby.
So then would you say this could already change practice in terms of patient guidance? You know, you could say you could have a lot more thorough history taking perhaps, or you could what would you recommend then? Because aren't 50% of pregnancies 50% of pregnancies tend to be unplanned. So how do we move the needle in the direction of more thought ahead of time?
I think that this has to be public education. It can't just be doctor-patient education. That's often too late, as you point out. One of the issues about Zika exposure, however, it's got a lot of public attention, and a lot of women and their partners are asking appropriate questions before pregnancy. So we get a lot of calls, a lot of patients coming in asking, well, is it okay to get pregnant if I was in Puerto Rico last year, as a for instance? And in many cases, we're able to be very reassuring, but in other cases, we have to really lay down the law with our patients and say, during this interval, as where you're working as a flight attendant and flying to the Caribbean or to Central America, do not get pregnant, period. There isn't a safe aspect of pregnancy when you're in an endemic Zika area.
So then sorry, go ahead.
There's also one point that I think we should at least address, and that is clearly another area of anxiety. Women who are exposed to Zika, potential Zika, I'm sure will have tremendous amount of anxiety regarding whether or not their fetus is affected. Mm-hmm. And I think the issue of screening, in utero screening, is one that I believe Dr. Harmon can address and is addressing now. You may want to comment further on that.
So when a woman reports that the coincidence of pregnancy and either travel or exposure to a traveler from an endemic area, then a series of investigations is put into place. A number of samples are obtained for testing to find out if the Zika virus is currently present in that pregnant woman. Most of the time that test is negative, but it has to be done, and that's done on urine and 2 forms of blood samples, which produce a very accurate picture of, is Zika currently circulating in that woman? Mm-hmm. Most of the time that's negative, and we have to resort to immune testing, IgM testing, to find out if she's been exposed to Zika virus itself. If that's positive, unequivocally positive, which requires several steps supervised by the CDC, then an amniocentesis is considered to test the amniotic fluid for the presence of Zika virus. Even if that's positive, that doesn't ensure that the baby's going to be affected, and serial ultrasound evaluation is another very valuable tool for detecting effects on babies. But I would emphasize that that's the current state of knowledge. We're starting to be suspicious that Zika virus has other effects, as do many congenital viruses. The primary effect is on brain tissue and tissue in the nervous system, but it may be that cases of stillbirth, which are markedly increased in Zika infection, are due to other effects, for example, affecting the placenta or the baby's adrenal glands or other functions that are central to, for example, fetal growth. Many Zika-infected babies are much smaller. Not only is their neural tube tissue affected, but their overall growth and development is also affected. So we're still learning about the broad range of Zika effects. It's a devastating disease if the fetus catches it.
And that's really a good point to remind us what we do know, because it sounds like there's so much, we're only becoming aware of what we don't know, particularly in the long term after a child is born and turns out to have been infected. So maybe, Dr. Neuzil, could you update us on what do we actually know? What are the vectors of infection? And
yeah, so I will comment that we're learning a lot, mm-hmm. and it's an evolving field. So, you know, what we know today, we'll know more next week, and we'll know more the week after. What we do know is that absolutely the predominant means of transmission is from a mosquito to a human. Unlike other sorts of mosquito-borne diseases, it doesn't appear that Zika affects animals or that there's any sort of what we would call an intermediate host. So that's the predominant way. Okay. We have learned that absolutely sexual transmission does occur. which is why it's so important what Dr. Harmon is talking about, understanding where the partner has traveled, where the man has traveled, and the precaution that you wait at least 6 months if the man has traveled before you plan a pregnancy. So we have learned that.
You would also have protected sex in that 6-month period.
You would have protected sex in that 6-month period.
Barrier protection is what I'm saying. Yeah.
Right. And then we're learning more about how long, so if a mosquito bites a human, then again, there's a period when the virus is in the blood, so that this could be transmitted by blood, when the virus might be in the tears or saliva, and that's going to be a shorter period of time than the virus might be in the sperm, for example. We think that's probably a period of weeks, not months. So again, there's additional precautions during that several weeks after getting Zika, when this virus could be transmitted through other body fluids.
It does sound really scary, but I'm also hearing you say put this in perspective. So, when a clinician is speaking with a patient, beyond public education in general, and is discussing family planning and also doing the history taking, you want to make sure you get the information about any travel between your patient and the patient's partner, family members, and so forth. But what would you recommend you say in terms of take it seriously but don't panic?
I think that's fair advice, but take it extremely seriously until the vaccine is available, because most women who have Zika don't know they have anything. There's no symptoms, there's no marks, there's no evidence that the person has been infected with this virus. So I think vigilance is really important. I don't think panic is appropriate. I don't think even high anxiety is appropriate. I think attention to detail about getting pregnant or refraining from getting pregnant is a very serious issue, not one that should have be overwrought by emotion. It should be very serious and very calculated. In order to prevent my child from contracting Zika effects, it's important that that baby is conceived in a safe situation, so no exposure and no planned immediate travel. Those aspects, I think, need to be emphasized in a public way. That's not going to be up to the doctors to communicate. The reassurance we can get from surveillance, from initial testing, by the way, we use urine as well, because the detection of Zika virus in urine seems to be intermediate. It's longer than blood, not as long as semen, but that's another valuable test that has been developed. And I would say that the most reassuring thing of all is the enormous power of medicine internationally to address each and every nook and cranny of Zika infection, and to actually come up in a very, very short period of time with effective public prevention that will eliminate what is extremely dangerous. And so, referring again to rubella, most women know that rubella is potentially dangerous, but most of them have a very high level of confidence that their own immune system will prevent their baby from being affected. And I think we're moving rapidly towards that reassuring status.
So, Dr. Reese, you mentioned that the center here has had a lot of experience internationally, and I guess you work a lot also with the World Health Organization. And so based on what Dr. Harmon is saying, I'm wondering, if there are lessons already learned in terms of, how this will go and what kinds of international response could be coordinated in the meantime while we're waiting for a vaccine, and, just shed some light on your experience already with the center.
Well, one of the things that I would say is that the center's footprint is broad. I mean, we have a number of sites. We call it Center of Vaccine Development, CVD is the acronym, in Mali, in Malawi, now in Myanmar, formerly Burma. We have a site also in Chile. So we have a number of sites across the world and we have faculty members in these locations studying various emerging infections and sometimes not so emerging. Malaria is another one of our big areas that is being studied. So, but again, as Dr. Harmon says, nothing is going to really change the needle. Of course, it's public education. That's a given. That's fundamental. But a vaccine is going to be critical to changing the whole impact. The good news is that once that's available, or once that's evolving, we'll be able to communicate this information rapidly across the world through our various agencies and partners. That becomes very important. We are well established, well connected with a number of, with the World Health Organization, or the Wellcome Trust in Britain, or a variety of other international global agencies. So our ability to interact, to disseminate information is very quick, is very well established. Unfortunately, there's a little time between now and then until we have that vaccine. But Dr. Harmon's point is well taken. Public education is critical in the avoidance or the prevention.
To say, because we're learning more about this virus and about where this virus is transmitted. Unlike, say, rubella or measles or influenza, which are highly contagious viruses. So I could be on a bus with someone, not realize that they have measles, and catch measles from them. We know, again, that predominantly this is spread through a vector, and we know here in the United States on October 4th, the only local transmission is in the state of Florida in the Miami area. So any other Zika that we've seen in the US is due to traveling. And so that's very important because again, majority of Americans will not be at a day-to-day risk of this virus. As Dr. Harmon and Dr. Reese have pointed out, it's a matter of public education, staying on top of the epidemic and understanding where it's occurring so we can give this guidance predominantly for travelers. And then it's very important from a public health perspective, the mosquito control aspect, and then also the personal protection from mosquito bites. It's not easy. These mosquitoes that transmit this virus are very aggressive daytime biters. You know, we're used to mosquitoes that bite at night, and that's much easier to control. These mosquitoes are difficult to control, but there are steps that people can take using insect repellents, for example.
Well, if a woman is bit, say she's 26, and she gets bit, and then she wants to start a family the following year. Well, that's beyond the scope of the viremia that we know of anyway at this point. So even let's say she's 30 and she wants to start a family, and she has had it verified that she was infected, regardless of her symptoms. Do you think that puts her at risk?
Well, at this point, our understanding is that in a woman, the duration of a viremia or when a pregnancy could potentially be affected, again, is a matter of weeks.
Okay.
So educating that woman to wait beyond that period from what we understand now would then be safe. And I want to make sure that's consistent with the current education that the gynecologists are given. But that's our current understanding of the virus in the body.
So cyclic reinfection from your partner might be an issue that prolongs the exposure radius. But as far as we know currently, a protective window of 6 months is perfectly adequate for all possibilities, other than going back to that same endemic place. And of course, a lot of people travel through their occupations to endemic areas. And to echo what Dr. Neuzil said, the mosquito is almost bred to spread an epidemic. It can reproduce using the water as small an area as in a bottle cap. So unlike many mosquito species which require large bodies of water to lay their eggs for the larvae to develop, Zika can do this in an urban environment. So the Zika virus or the Zika mosquito, that's a combination of things that's very dangerous at the moment. But to give reassurance, proper protection, planned pregnancy, and most of all, the effective vaccine that's now on the horizon, This is going to relegate Zika into the annals of perinatal medicine. It's going to become a story where the power of modern medicine has defeated an epidemic that had enormous potential for harm.
Well, so how far away is that? 2 years? What do you think?
Yeah, I've learned not to predict when we will have a vaccine.
Is that because this is acting in a way that's different than any other kind of vaccine study you've been?
No, I don't think it's acting in a way that's different. It's just that, again, you know, in the United States, elsewhere in the world, we recognize that we generally give vaccines to healthy people to prevent what will be only a fraction of them getting disease, as my colleagues have explained. And therefore, we really put an incredible emphasis on safety. And it is highly unlikely for any vaccine to be licensed until it's tested in thousands and not hundreds. Now, the Ebola is an example. It's a very good example of how we can accelerate vaccine development in a public health crisis. And so while in the United States we're certainly concerned, you know, really where this vaccine is needed most is in other countries, is in the Caribbean, is in South America, is in parts of Asia and some of the Pacific Islands right now.
But this is not the only vaccine study either, so there are going to be lots of other data there will be more data coming
There
in.
are other vaccines in development. So I hope that, you know, we're talking a year, a couple years, but again, it can be very difficult to predict. We haven't even seen the immune response to the first vaccine yet.
Anything else that anyone would like to add that is important for our audience to know and that we haven't touched on yet?
Well, I would tag on to what Dr. Neuzil said. The additional good news, partly due to the CVD and partly due to many other foundations and organizations around the world, is the way that the successful vaccine will be implemented. A lot of that has been worked out already too. So the cooperative nature of public health initiatives in Africa, in Asia, in underdeveloped countries is phenomenal. So we're going to be able to apply this successful vaccine. This isn't going to be a decade-long rollout. This is going to be accomplished with alacrity. And my view on how fast this is going, I would say within 5 years there'll be effective public preventative programs and Zika will start to recede in our consciousness.
And your experience is having been a part of other vaccine responses or infectious disease responses here at the center. It is that communication network is so strong that 5 years seems like a workable time based on.
I'm like Dr. Neuzil. I don't predict because prediction is so very much. There's so many variables in between. What I can say is that when it's available, we do have the network that we can disseminate and propagate information and even the vaccine itself. We have very, very good network in making the vaccine available in various parts of the world. So that part we're very good at. We have experience in doing that. We have in a number of areas. So I think that is to me the good news. The assurance is having a place like ours, the Center for Vaccine Development here at the University of Maryland, that has extensive experience in not just the development, but the dissemination, the coordination of such therapeutics and vaccines across the world.
Well, I'd like to thank all of our guests today, and thank you very much, Dr. Rees, for having us here today. And
it's a pleasure.
And if you'd like more information about the development of the vaccine or any updates on CDC recommendations for treatment with your patients or for guidance with your patients, you can go to our website.